Hi, everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today. And don't forget to follow us on social media and subscribe to our YouTube channel. And just want to remind you that you have some activities happening this month. So on the 12th of February, we are going to have this very interesting meeting. It's the second one. Last year, it was very nice about Epstein anomaly from the Hospital of Pittsburgh with Dr. José Pedro da Silva and Dr. Luciana and all the team there. It's going to be very nice. So I hope you all can join us on next Saturday. And we are happy to have restarted the webinars from Dr. Silverman. The first one was on the 1st of February, it was very nice. If you missed it, take a look on the YouTube, it's there. And the next one is going to be on the 1st of March, talking about echomorphological comparisons for hypoplastic left heart syndrome. I'm sure it's going to be awesome. And we are happy that Dr. Mary Cohen is going to restart her series as well. The first one is going to be in the beginning of March. A reminder for all of the surgeons who are with us today, if you have the chance to register for this very nice activity from our friends from SigKids. This is a 3D hands-on training in interesting procedures. You're going to have all the tips and tricks for this surgery. So take a look on this website and you're going to have more information about it. And today we are going to have Dr. Anderson and Diane, Adrian, and Justin with their beautiful images and this very nice panelist. So please type your questions on the Q&A chat box. I'm sure everybody's going to be very happy to answer your questions in the end of the session. Just a second. Share again. I found it.
Well, good afternoon to you, ladies and gentlemen. You'll remember that over recent sessions, we've been discussing the anatomy of the normal heart. So for the next 3 sessions, we want to evolve from the understanding of the normal heart to the understanding of the congenitally malformed heart. And we'd like to discuss with you the evolution of our own understanding. And it has represented what I call a paradigm shift. Because nowadays, we use a logical approach when we're trying to analyze the congenitally malformed heart. That was not the case in my own career, which is quite a time ago now. There was the tendency to try to pigeonhole lesions, and some of the lesions could not properly be pigeonholed. And it was the need to introduce a logical approach that was crystallized by the recognition that looking at right-sided hearts, for example, didn't fit a particular pigeonhole. And there were problems also in analyzing hearts that were functionally univentricular. And it was the attention to these entities that produced the beginning of a logical approach. And here are the 2 significant publications that started the evolution of understanding of the congenitally malformed heart. As you can see, they come from 1964. The top one is related to the functionally univentricular heart. The bottom one, which appeared very shortly thereafter, was concerned with the analysis of hearts that were positioned in the right chest. And the thing that came out of all of that was what we now call segmental analysis. And you are all well aware that it was Richard van Praag who introduced this notion of segmental analysis along with his wife, Stella. And this was what was emerging as I started my own career. So I became particularly interested in the congenitally malformed heart in 1973 when I was working in Amsterdam with Anton Becker. And when we started our own studies, this summary of the segmental approach had only just appeared. And here is Richard, together with Stella. Sadly, Stella no longer with us. Richard is still active, and I'm told he still goes in to his archive, which is set up in Boston, that is now curated by Steve Sanders, who is a consummate echocardiographer, but now has returned to continue his interest in the anatomy of the congenitally malformed heart. And so it was Richard who started what we call segmental analysis. When I began in London in 1974, I met Richard at a very early stage of my own career because Elliot Scheinborn, a pediatric cardiologist with whom I was working most closely, had been greatly influenced by the teaching of Richard and by the emergence of the segmental approach. So why then, if we were so interested in the segmental approach, have the difficulties emerged that we're going to be discussing with you today? Well, not only was I working at that time with Elliot Scheinborn and also with Anton Becker. Anton was a pathologist. I am as an anatomist. We worked very closely together. But we were also joined in London at that time by Fergus McCartney, who became professor of pediatric cardiology at Great Ormond Street, and then by Michael Tynan, who at the time was the professor of pediatric cardiology in Newcastle. But he very soon came down to London and set up the unit at Guy's Hospital. And we worked together and we wanted to apply the segmental approach to the understanding of the congenitally malformed heart. And when we produced our own system, we thought we were doing no more than making minimal changes to Richard's own segmental approach. And indeed, Anton Becker and I visited Richard in Boston in 1976. And again, we were very much of the opinion that we were moving along exactly the same line. So why did problems emerge that we are still trying to solve today? Well, the beginning of the problem was how to differentiate between the components of the segments that Richard had identified. But the real problem came when we discussed how we were going to describe the way in the segments were connected one to the other. More importantly, how on occasion they were not connected to one another. And that led to what I'm going to call the schism. And Richard's approach to resolving this schism was to suggest that not only were there the original segments, but also there were what he called connecting segments. I'm going to discuss all that with you over the next 40 minutes or so as we consider the way that our understanding has evolved. So I'm sure you're all aware that the real revolution introduced by Richard was to analyze congenital cardiac malformations on the basis of their segmental makeup. And Richard introduced this notion of atrial, ventricular, and arterial segments. So let's look at these segments. I'm sure you all know what they are, but I'm going to revisit this with you. More importantly, let's look at the boundaries between them. So here you'll immediately recognize we have the atrial segment of the heart. And there we have what we can call the ventricular mass. Then the third segment, of course, is the arterial trunks. Now, when Richard introduced the segmental approach, clinicians were identifying these segments using angiography, and echocardiography at that stage was very much in its infancy. And in a way, we were fortunate, because when we came to what we thought was tweak the segmental approach, this coincided with the introduction of cross-sectional echocardiography. And now, for the first time with cross-sectional echocardiography, not only could you look at segments, but you could also look at the way they were joined together. So echocardiography gave us the opportunity to look at what was happening at the atrioventricular junctions, how the atrial chambers were connected to the ventricles. On occasion, they were not connected. And then we could also look at the ventricular arterial junctions, and we could work out with much more accuracy how the arterial trunks arose from the ventricular mass. And this was perhaps the beginning of those differences that have subsequently emerged and have been responsible for the two nomenclatures that now exist. So the first problem that arose was how we should differentiate between the components within the segments. In other words, how are we, or how were we, to determine what is morphologically right as opposed to what is morphologically left? And in fact, it was the arguments that arose on the way we should differentiate rightness from leftness that introduced what I now think of the second great revolution, again produced by Richard van Praagh. And I've discussed this with you on several previous occasions, but it is the morphological method. So let me remind you again what Richard pointed out when introducing this second revolution was to emphasize that when we were distinguishing between the parts of the segments, we should identify them on the basis of their most constant components. And this was the work in which he introduced us to the morphological method. It was a letter to circulation related to an argument, not an argument, to it related to a publication that we had produced on double inlet right ventricle. And it all devolved on how we were to identify the second chamber that exists in the setting of double inlet right ventricle. And in this letter, Richard pointed out that we should use the most constant component to identify the ventricular chambers, this of course being the apical component. And this was the basis of the morphological method which we've used ever since that time. But if we are to use the morphological method, of course, we need to know how many parts there are in each half of the segments, because each of those segments has a half. One half is morphologically right, the other half is morphologically left. So to begin our understanding of the congenitally malformed heart, let us revisit the way we identify these components of the normal atrial chambers. You've seen this already, but we're going to revisit this both from the stance of gross anatomy and from the stance of what you can now see with interrogation of computed tomographic data sets. So we're going to start by revisiting the atrial chambers. I hope you will remember that I've told you during development, each of the atrial chambers has a small part of what we call the body. And this is the primary heart tube. But in the definitive heart, the body has no distinctive features. The most obvious features of each atrial chambers are the venous components. And indeed, it is those components that were used and still are used by Richard to distinguish between what is morphologically right and what is morphologically left. But there are more components, as you know. There are the vestibules, the myocardium that inserts into the atrioventricular junctions around the orifices of the atrioventricular valves. And we'll come back to that shortly when we also discuss the ventricles. There is the septum, but the septum's not always present, so we cannot use that as a differentiating feature on all occasions. But there is then that other component of the atrial chamber, namely the appendage. So let's look again at these components in the setting of the normal heart. And to do that, I'm joined again by Diane Spicer. So now Diane is going to show you how in the atrial chambers we can identify these components. And then we're going to be joined again by Justin Tretter. And Justin is going to revisit the virtual dissections that he's already shown you in our previous discussions of the normal heart.
Both atriums have 5 components, and we'll start on the right by looking at the shape and extent of the right atrial appendage. The appendage has a broad, blunt tip, and it also has a broad junction with the venous component. The atrial appendage consists of this entire anterior aspect of the right atrium. The venous component has the superior caval vein entering the roof of the atrium and the inferior caval vein its floor. Along the area of my incision would have been the terminal groove, and just anterior to that is this prominent muscle bundle, which is the terminal crest. And the pectinate muscles extend in parallel fashion around the anterior aspect of the right atrial appendage from that terminal crest and also around the right atrioventricular junction. The venous component is here where that appendage had its broad junction, and you can see that it is a smooth component of the right atrium. Another smooth component is the tricuspid valve vestibule, which is this smooth circumferential area that extends between the hinge point of the tricuspid valve and the distal extent of the pectinate muscles. The atrial septum is made up of the flat valve at the floor of the oval fossa and the anterior inferior muscular buttress. Another venous structure that enters the right atrium is the coronary sinus, which is here. The body of the right atrium is that area between the floor of the atrium, or where the inferior caval vein joins the atrial floor, and the inferior aspect of the oval fossa. And many times in this area, you can see a few little fenestrations because this is where the left venous valve gets resorbed. And in the right atrium, it is a fairly nondescript area. The morphologically left atrium has the same 5 components as we saw on the right. And the left appendage is typically a tubular structure with scallops or crenellations along its edge and a very narrow attachment to the venous component. The venous component is composed of the pulmonary veins. So here are the left pulmonary veins and here are the right, entering the roof of the left atrium. The appendage has a very narrow attachment with the left atrial vestibule, and the pectinate muscles are confined to the appendage. So the left atrium has no terminal groove or no terminal crest. The left atrial vestibule is smooth around its entire circumference, and the body of the left atrium is a remnant of the embryonic atrial wall, and it is the site of union between the appendage, the septum, and the atrial vestibule. The atrial septum is made up of the left aspect of the flap valve at the floor of the oval fossa, and you can see this typical horseshoe arrangement where the horns of the flap valve become adherent to the superior interatrial fold. I'll also mention that the coronary sinus is a left atrial structure morphologically, and it lies in the left atrioventricular groove.
This is a different normal adolescent cardiac CT data set. We're again starting in an X-ray or fluoroscopic appearing image in a straight anterior posterior plane where we can appreciate the cardiac silhouette. And we'll again put the heart back into the chest, filling the blood pool, and we'll rotate into a right anterior oblique plane. And we can appreciate the right coronary artery running in the right atrioventricular groove and then coursing around the inferior or diaphragmatic surface. Looking at the right atrium, we can appreciate this broad-based right atrial appendage. And if we rotate further, we can see how that appendage extends back into the right atrium, back towards this groove coursing between the superior to inferior cable veins, the terminal groove. And then if we dissect into the heart in this plane, removing the free wall of the right atrium and the right ventricle, we can appreciate the right atrioventricular junction, and we can see this septal leaflet of the tricuspid valve. It's difficult in this scan with, again, heterogeneous opacification of the right atrium and a relatively thinner tricuspid valve, but we can see this septal leaflet of the tricuspid valve. And if we look at the right atrium, we can again see this broad-based atrial appendage with pectinate muscle, the pectinate muscle extending outside its confines down towards the vestibule. We can appreciate this thick muscular structure, which is the terminal crest, which is on the inside of the heart, where we saw that terminal groove extending between the cable veins, near the venous portion of the right atrium. If we look at the rightward aspect of the atrial septum, we can see the floor of the oval fossa, and it's surrounded by the so-called secondary septum in a C-like configuration, which is really interatrial infolding in the superior, posterior, and inferior aspect around the floor of the oval fossa. Anterosuperiorly, we can appreciate this mound from the aortic root, which is formed by the non-coronary sinus, so-called aortic rims when interrogating that by 2- and 3-dimensional imaging. Anterior and inferiorly is the muscular buttress, the true secondary septum, extending from the floor of the oval fossa anteriorly towards the triangle cock in the right atrioventricular junction. And then if we tilt to look up at the superior cable vein and then dissect into the superior cable vein, we can better appreciate this ridge extending between the cable veins, again, that terminal crest that we see on the inside of the heart. And then we'll rotate into a short axis at the base of the heart in a surgeon's view. We can see the aortic root wedged in between the atrioventricular junctions. And we're at the superior aspect of the right atrium here. We can see this broad-based atrial appendage with pectinate muscle within. And then as we dissect further into the right atrium, and then we'll tilt it, so we're looking directly anteriorly at the anterior free wall of the right atrium and the right ventricle, we can again see that broad-based atrial appendage, better seeing the pectinate muscle extending outside of the confines of the right atrial appendage down to the vestibule near the tricuspid valve, here being the anterosuperior leaflet of the tricuspid valve. And then we'll dissect it further to better appreciate from this aspect the terminal crest, which is extending between the cable veins with that pectinate muscle coursing down to the vestibule, down to the terminal crest. Using the same normal adolescent CT data set, we'll again start in that anterior posterior fluoroscopic-like view with the cardiac silhouette. We'll again put the heart back into the body, and this time we'll rotate leftward to view that smaller left atrial appendage. Then we'll dissect into the heart into a 3-chamber view. We're viewing the leftward aspect of the interatrial septum here and the interventricular septum. If we look at the interatrial septum, we can appreciate those horns to that superior posterior aspect of the floor of the oval fossa on the leftward aspect of the interatrial septum. We'll then go into more of a 4-chamber-like view, and you can appreciate this larger, smooth body component along with the venous component with the pulmonary veins coming into the backside of the left atrium. And there are the left pulmonary veins, and directly anterior to those is this smaller left atrial appendage. And then we'll dissect to open up to the tip of this left atrial appendage. So now we're looking at the leftward free wall of the left ventricle and left atrium. We can see the mural leaflet of the mitral valve with this left atrial appendage opened up, with the pectinate muscle contained within the appendage, with a very smooth vestibule leading up to the mitral valve. We can also see the entrance of both the left upper and left lower pulmonary veins. And then we'll dissect back over towards the right side to look at the right pulmonary veins. Again, a very large, smooth body and venous component to the left atrium.
So that's how we look at the atrial chambers, and we now, using the morphological method, use the appendage to distinguish between what is morphologically right and what is morphologically left. And that, as I say, was the first major disagreement between the systems, because Richard uses the venous connections. But is it justifiable to use the venous connections? And in fact, using the morphological method, we determined it was not appropriate to use veno-atrial connections because they themselves are variable. And most importantly, they are variable when you need them most, which is in the setting of so-called heterotaxy. So is there an alternative way to distinguish what is morphologically right and what is morphologically left? And of course, you know that there is, because we've shown you this when we discussed the normal atrial chambers. And the most obvious difference between what is morphologically right and what is morphologically is the extent of the pectinate muscles relative to the vestibules. So now we're going to revisit this. Again, Diane is going to show you what we see when we have the heart in our hands. Justin is going to revisit what you can now do using virtual dissection.
We know that our atriums have a characteristic outward shape to their appendage. On the right, we have a triangular tip with a broad junction with the venous component. Along that broad junction, when we open the atrium, we can see that terminal crest from which the pectinate muscles extend. And the pectinate muscles extend around the entire right atrioventricular junction. So around that smooth vestibule of the tricuspid valve, the pectinate muscles interpose between this smooth vestibular component and the smooth venous component. I'll point out as well that the pectinate muscles extend over the inferior atrioventricular groove and over the inferior pyramidal space, so that this is all right atrial appendage. So here we can see nicely that our morphologically right atrium is our pectinated atrium with the pectinate muscles extending around the right atrioventricular junction. The left atrial appendage is a tubular structure with a very narrow junction to the venous component. The pulmonary veins enter the roof of the left atrium. And when we look at the left atrial vestibule, we can see that it is smooth in its entirety. There is the narrow junction of the appendage with the atrial vestibule, and the pectinate muscles remain confined to that appendage. So that the right atrium is our pectinated atrial appendage, and the left atrium has a smooth atrial vestibule with a narrow junction of the appendage to the atrium and the pectinate muscles confined to the appendage.
Thank you, Professor Anderson. So here we're looking at a CT data set of a patient with normal segmental anatomy. And we're starting looking up from the head of the data set. And then as we zoom up and we'll start to dissect into the base of the heart. So there we see the pulmonary and the aortic root. And here we see both the mitral valve, and then on the right here in a surgeon's view, we see the tricuspid valve. So because of the contrast opacification timing, we have very heterogeneous opacification into the right atrium, so not as clean of a view. But if we look at the left side and we see this narrow finger-like left atrial appendage with the pectinate muscle extending within the appendage, but as we position it so we can start to view the vestibule, we can see that the pectinate muscle is contained within the atrial appendage and not extending to the left atrial vestibule. So a very smooth wall leading down to the mitral valve. And then as we focus over on the right atrium, again, a little more heterogeneous opacification, so not as clean of a view, but we see this broader base atrial appendage. And as we dissect superiorly into the appendage, you can appreciate the pectinate muscle here near the tip of the appendage. But then as we start to focus at the base of the appendage, leading outside, extending outside of the confines of this broad-based right atrial appendage, we see the pectinate muscle coming down to the vestibule near the tricuspid valve within the right atrium. And then as we dissect, so we can focus on the anterior and rightward wall of this right atrial appendage, you can again appreciate this very broad-based, relatively larger right atrial appendage with that pectinate muscle extending outside of its confines down to the vestibule of the right atrium near the tricuspid valve. And then we'll switch into an endocast view. So looking at the blood-filled cavities and vessels of the heart. And here we're looking at a right anterior oblique view at the anterior aspect of both the right atrium and the right ventricle. And again, we can appreciate that very broad-based right atrial appendage with its base extending from the terminal groove, which is extending between the caval veins. And as we rotate leftward into a left anterior oblique view, we can appreciate this relatively smaller and narrow base or finger-like appendage of the left atrium.
So there's no question now, when we have the heart in our hands, and now what you can do yourselves using virtual dissection of computed tomographic data sets, you can distinguish the extent of the pectinate muscles relative to the atrioventricular junctions, the vestibules. So what you are looking at there is a picture, atrial mass, in which the pectinate muscles on the right side of the patient, your left hand as you look at the patient, the pectinate muscles extend crux. To your right hand, left side of the patients, there is a smooth vestibule with the pectinate muscles confined within the tubular appendage. And we now know that that is the essence of usual atrial arrangement. We also know that in a very small minority of patients, we have mirror imagery. And so in mirror imaged arrangement, pectinate muscles are found on the left side, my right hand as we look at the image, whereas the smooth vestibule is found on the right side of the patient. But by using the pectinate muscles, this permitted us always to distinguish between the two subsets of what many of you probably still call visceral heterotaxy. And we now know that when we look at the atrial chambers from patients known to have visceral heterotaxy, they fall into two subsets. They either have pectinate muscles extending to the crux on both sides, encircling the entirety of the atrioventricular junctions. In other words, they have isomeric right appendages, or they have smooth vestibules on both sides with tubular appendages, isomeric left appendages. Having identified the isomeric appendages, however, we need to remember the veno-atrial connections. And we've emphasized to you that we don't use the veno-atrial connections so as to determine atrial arrangement, but we still need to know how the blood comes back into the heart. And on occasion, even when we have isomeric appendages, the venous drainage itself can be usual or mirror imaged. But the finding of these quasi-usual or quasi-mirror imaged veno-atrial connections does not detract from the fact that the appendages are isomeric. And it is the isomeric nature of the appendages that needs to be our starting point of sequential segmental analysis. So to show you the importance of this, Diane is now going to illustrate to you a situation where the appendages are isomeric, but venous drainage is such that it has all the systemic veins coming to one of the atrial chambers, the pulmonary veins all coming to the other atrial chamber.
Cases with isomeric atrial appendages can have highly variable veno-atrial connections, and they must be adequately described. This patient has the apex of the ventricle removed, and we're just looking at the base of the heart. We can see the aorta directly anterior to the pulmonary trunk. There were bilateral morphologically left atrial appendages. So here is our right-sided appendage that is tubular with the narrow junction to the atrial vestibule, which is actually quite dilated hemodynamically in this case. And here is the left-sided morphologically left appendage with its tubular appearance and narrow junction to the atrial vestibule. If I turn the heart around, we can see that this specimen exhibits quasi-usual veno-atrial arrangement so that the superior cable vein enters the roof of the right-sided morphologically left atrium, and the inferior cable vein joins the floor of this right-sided morphologically left atrium. This large structure that has been cut from the superior cable vein is the azygous vein. So this patient had interruption of the hepatic portion of the inferior cable vein, or azygous continuation. If we look at the left-sided morphologically left atrium, we see the left pulmonary veins and the right pulmonary veins all joining this left-sided morphologically left atrium. So this heart exhibits quasi-usual veno-atrial arrangement. This is another specimen with isomeric left atrial appendages, and the apex in this specimen was pointing to the right. On the left, we see a tubular appendage with a narrow junction to the atrial vestibule, or the atrial chamber, which you can see is hemodynamically dilated. On the right, there is also a tubular appendage with a narrow junction to the atrium. On the left, there was a superior cable vein joining the roof of the atrium, and the inferior cable vein joined the floor of this atrium. The azygous vein, which in this case has also been cut from its junction with the superior cable vein, was very large, as this patient had interruption of the hepatic portion and azygous continuation of the inferior cable vein. Within the left-sided morphologically left atrium, there's a very large coronary sinus. You can see the rims of the sinus where my probe is moving. Looking at the right-sided morphologically left atrium, there was a persistent right superior cable vein, which when probed, drained to the left-sided morphologically left atrium, or to the coronary sinus. The pulmonary veins also drained into this right-sided morphologically left atrium, so that this specimen exhibits quasi-mirror image veno-atrial connections.
So that's now how we look at the atrial segment of the heart. We recognize the atrial segment on the basis of the appendage, but we always take note of the veno-atrial connections. Arguably, you could consider the veno-atrial connections as a different segment, but we don't think that's the best way to do things. We simply describe what is going on in terms of veno-atrial connections, and if they are abnormal, we think of those as associated malformations. So let's move on and let's look at the ventricular mass, because that was another potential bone of contention. How many parts are there within ventricles? Now, again, when I started, it was usual to think of the ventricles as having sinus conus. But we've seen from our previous discussions that that does not always work. But how we define the ventricles also depends on their extent. So from the outset, we've taken the stance that the ventricular mass extends between the atrioventricular and the ventricular arterial junctions, and they are clear-cut anatomical boundaries. And when we assess the ventricles in this fashion, there's no question that it is an easy matter to analyze each chamber within the ventricle mass, with ventricular mass as having an inlet, an atrioventricular valve, an apical trabecular component, an outlet. And it is the apical trabecular component that is most constant, and it is that part which we use to distinguish between what is morphologically right and what is morphologically left. So let's revisit this again now, and let's summarize how we analyze ventricles, again with Diane showing you gross specimens and Justin showing you virtual dissections.
Here we're looking at a morphologically right ventricle in attitudinally appropriate fashion so that the diaphragm or inferior aspect is along my probe. The ventricles have an inlet, an apical trabecular, and an outlet component. Within the inlet of the right ventricle, we have the tricuspid valve, which is a morphologically right structure and will always travel with a right ventricle. The tricuspid valve inlet extends from the hinge point of the valve at the atrioventricular junction to where the tendinous cords attach to the septal surface and to papillary muscles. The right ventricle is morphologically determined by its coarse apical trabecular component, and the septal surface is often trabeculated as well. On the septal surface, there's a prominent trabeculation, which is the septomarginal trabeculation or septal band. It has a cephalic arm, which rises up to be incorporated into the subpulmonary infundibulum, and a caudal arm, which extends back to join the inner heart curvature. Also branching from the septomarginal trabeculation is the moderator band, which when I put the free wall back, you can see it was joining the anterior papillary muscle and crossing the cavity of the right ventricle. The septoparietal trabeculations also arise from the septomarginal trabeculation. The subpulmonary infundibulum supports the pulmonary valve within the outlet component of the right ventricle, and it is a complete muscular sleeve that separates the arterial valve from the atrioventricular valve. The left ventricle as well has an inlet, an apical trabecular component, and an outlet. Within the inlet component is a mitral valve, which is a morphologically left structure and will always travel with the left ventricle. So the inlet extends from the hinge point of the mitral valve at the atrioventricular junction to where the tendinous cords attach to the tips of the papillary muscles. And the mitral valve is supported only by papillary muscles with no attachments to the interventricular septum. The papillary muscle support extends equally to each of the leaflets of the mitral valve. The mitral valve has a very broad leaflet, the anterior leaflet, which makes up 1/3 of the valvar circumference, and then the remaining 2/3 is made up by the mural leaflet, which is a much more shallow leaflet. If we look at the anterior leaflet of the mitral valve, you can see that there are no septal attachments, and the anterior leaflet is all that separates the inlet from the outlet within the left ventricle. The apical trabecular component is fine and crisscrossing and is the morphologic determinant for the left ventricle. The septal surface typically becomes smooth as we extend towards the outlet, where we have the aortic valve, which has partial muscular and partial fibrous support. The anterior leaflet of the mitral valve is where we have the fibrous support, and it is in fibrous continuity with the non-adjacent or the non-coronary leaflet of the aortic valve.
We've seen this data set before. It's an adult patient with normal segmental anatomy, but with severe aortic stenosis and resulting left atrial and left ventricular dilatation and left ventricular hypertrophy. We can appreciate that even though the left ventricle is heavily trabeculated for a normal left ventricle, we see these important structures of the inframedial in the superior lateral papillary muscles with no clear attachments to the ventricular septum. Looking at the right ventricle, we can appreciate the anterior papillary muscle and the inferior papillary muscle. And looking at the base of the anterior papillary muscle, and as we start to dissect anteriorly, we can see the attachment of this moderator band to the base of the anterior papillary muscle here. We'll continue to dissect anteriorly, paying attention to the right ventricle, and then we'll rotate over into more of a right anterior oblique view, looking at this moderator band attachment to the base of the anterior papillary muscle. We'll come all the way over into right anterior oblique view with the free wall of the right atrium and right ventricle removed, looking at the rightward aspect of the atrial and the ventricular septum, and paying attention to the ventricle, appreciating its tripartite anatomy. So here's the septal leaflet of the tricuspid valve, and with its chordal attachments to the septum. And this important structure we talked about before, the medial papillary muscle or papillary muscle of Lancisi, which is attaching right somewhat anterior to its usual location at the posterior caudal limb of this structure here, the septal marginal trabeculation. So the septal marginal trabeculation dividing into its anterior cephalid and posterior caudal limb, with this medial papillary muscle attaching here at the base of the posterior caudal limb. And then if we rotate further, you see this unusual, almost bifid appearance of a moderator band, but it's attaching to the base of the anterior papillary muscle and attaching at the septum at the base of the septal marginal trabeculation. Looking at the papillary muscles, we can see they're much more coarse, or the trabeculations are much more coarse when we compare it to the left ventricle. So we can easily define coming back to this right anterior oblique view, we can easily define the inlet component extending down to the chordal and papillary muscle apparatus attachments to the septum. So that defines the inlet up to the annular attachment of the tricuspid valve, the apical trabecular extending from the inlet down to the apex and up to the outlet. The outlet we define by looking at the septal marginal trabeculation and its limbs, cradling between its limbs the ventricular mandibular fold and the supraventricular crest, with the outlet extending from the limbs of the septal marginal trabeculation and then anterior and superiorly up to the outflow or to the pulmonary root. So here we see the semilunar attachments of the pulmonary root, and we can appreciate this darker appearance of the ventricular myocardium versus the arterial wall. So this anatomical ventricular arterial junction, which in the pulmonary root is a circumferential structure. And then we'll rotate over, now cutting in a short axis, looking from the apices of both ventricles up at the right ventricle and the left ventricle, seeing both inlets of the ventricles and then seeing the outlet of the right ventricle leading up to the pulmonary root, better appreciating this ventricular mandibular fold and supraventricular crest. And now looking over at the left ventricle. So the left ventricle, as we all know, has two papillary muscles, the superior lateral and inframedial papillary muscles, are commonly referred to as the anterolateral and posterior medial. But when we look in an attitudinally correct fashion, we can appreciate how they're positioned more superior and inferiorly. And those support the aortic leaflet and mural leaflet of the mitral valve. Then going into a three-chamber view, we can better appreciate the tripartite nature of the left ventricle, with the inlet again extending from the annular plane of the mitral valve down to its chordal and papillary muscle attachments, the apical trabecular component extending from that plane down to the apex and then up to the outflow, with a much smaller outflow than the normal right ventricle, related to the development with resorption of the subaortic infundibulum, leading to this important relationship, the fibrous continuity between the aortic leaflet and the mitral valve and the aortic valve. So a much smaller outlet. And importantly, even though heavily trabeculated left ventricle compared to normal, there's a very smooth outlet compared to when we look back at the right ventricle, where we have those septal-parietal trabeculations between the septal marginal trabeculation and the free wall of the right ventricle. So very trabeculated right ventricle extending not only down from the apex, but all the way out to the outflow to the pulmonary valve. So coming back to this 3-chamber view for comparison.
Another potentially contentious topic is the interrelationships of the ventricles within the ventricular mass. And we've discussed this again recently. And we pointed out that when we look at the majority of hearts, almost all of them have 2 ventricles present, and those ventricles can be arranged in usual fashion or in the mirror image variant. Richard van Praag identified these as the D and L loops. And as you know, we think of these as right-handed and left-handed topology. We've discussed this at length in recent sessions, so let's revisit again how we determine right-handed and left-handed ventricular topology. And Diane is going to illustrate that to us, showing us hearts with the 2 variants.
The normally formed right ventricle wraps itself around the left ventricle, permitting 2 basic arrangements with reference to topology. So here we see an opened morphologically right ventricle with its coarse apical trabecular component. And I can place only the palm of my right hand on the septal surface with my thumb in the inlet and my fingers in the outlet. This demonstrates right hand ventricular topology. The second basic arrangement that we see is in the morphologically right ventricle on the left side of the heart in those hearts with congenitally corrected transposition. So that in the inlet, we have our tricuspid valve, we have our coarse apical trabecular component, and the aorta within the outlet component supported by a complete muscular infundibulum. And if I place the palm of my left hand on the septal surface with my thumb in the inlet and my fingers in the outlet, this exhibits left hand ventricular topology.
So now we know how to analyze the atrial segment. We do that on the basis of what's happening with the appendages. They are the most constant component. We know how to distinguish between morphologically right and morphologically left ventricles. When all components are present, we take advantage of them, but final analysis, we look at the apical components, and it is the nature of the apical trabeculations that distinguish what is morphologically right, what is morphologically left. The third segment of the heart, of course, is the arterial sector. And here we have a potential problem because there are no direct distinguishing features to tell one arterial trunk from another arterial trunk. But it is very fortunate that it is the branching path that permits us to distinguish between the arterial trunks. And in my experience, I've always been able to distinguish what is aortic and what is pulmonary. As you know, in the normal heart, there is combined an aorta and a pulmonary trunk, but in the malformed heart, we can have common trunks, and then we can have this further variant, the solitary arterial trunk. And so here, the branching path is the key distinction. And Diane now is going to illustrate to you how you can use these branching patterns to distinguish the different types of arterial trunk.
We can identify the arteries by their branching pattern, and this is the aortic valve. The first branches from the aorta are the coronary arteries. This is the right coronary orifice, which will give rise to the right coronary artery. And here's the left coronary orifice, which we can see the left main coronary artery extending from the aortic root. The remaining branches that identify the aorta are the brachiocephalic arteries that extend from the aortic arch. Here we see the brachiocephalic trunk that would have bifurcated into the right subclavian and the right carotid artery. Here is the left carotid artery and the left subclavian artery. The pulmonary trunk is also identified by its branching pattern. So here I'm tugging on the branch that extends to the left lung or the left pulmonary artery, and the right pulmonary artery will extend behind the aorta and behind the superior caval vein to the root of the right lung. This specimen has an arterial ligament, which at one time was a patent arterial duct. A common arterial trunk gives rise to arterial branches that supply the coronary circulation, the pulmonary circulation, and the systemic circulation. The first branches are the coronary arteries. There's the left coronary orifice there, and here is the right coronary orifice. The next branches are typically the pulmonary arteries, and in this case, we see the left and right pulmonary arteries arising in separate fashion from the common arterial trunk, whereas in other cases, a common pulmonary trunk can arise from the common trunk and then bifurcate to the left and right pulmonary arteries. The next branches arise from the arch, and they are the systemic arteries that will supply the systemic circulation. Cases with a solitary arterial trunk have no identifiable pulmonary trunk within the intrapericardial space. This aorta arises as the solitary arterial trunk from the ventricular mass. Here you can see the left coronary artery as it's been bisected, leaving the aortic root, and there is the right coronary orifice. The pulmonary arteries arise distally from the aorta, and here you can see where the right pulmonary artery arose from the base of the brachiocephalic trunk. The left pulmonary artery also arose from the aortic arch in a similar position to where we would see the arterial duct. The left lung has been removed in this particular case, and there are the left carotid and the left subclavian arteries.
So there we have it. We know where the segments are. We don't differ in distinguishing between the segments from Richard Van Praagh. We use marginally different ways of telling what is morphologically right and morphologically left, but there's not a great difference. So why did so many differences seemingly arise in the way we describe the congenitally malformed heart? And much of that relates to concordance, discordance, as opposed to concordant and discordant connections. Now, the difference in these is remarkably subtle. It was so subtle, for at least 10 years, I did not appreciate what the problem was that we were creating. We've discussed this briefly with you before, but let's go through it again, and let's look at the difference between concordance and concordant atrioventricular connections. So we can start that by looking at the normal heart. Now here on the screen, in front of you, to the left hand, you see the segmental makeup across the atrioventricular junctions of the normal heart and the patient who has usual atrial arrangement with right-handed ventricular topology. To your right hand, you see the mirror-imaged variant of the normal heart. And of course, in the mirror-imaged variant, we have mirror-imaged atrial chambers, and then we have the mirror-imaged ventricular topology, and that is left-handed topology. And this is what, when we started our own sequential segmental approach, we called atrioventricular concordance. And indeed, this is also what Richard was calling atrioventricular concordance. So let's look at the way that Richard analyzed atrioventricular concordance. It's the same heart I was showing you just a moment ago. As you know, when Richard describes the atrial chambers, he considers them to have solitus, and in his segmental abbreviations, he calls that S. And then with ventricles, he talks about the ventricular loop. In the normal heart, we have the D ventricular loop, which he abbreviates to D. So that is the normal heart. What we had not appreciated at the time But if we look at a heart like this, you see has cytosolitis, S. If you look at those atrioventricular valves, you'll see they're both going into the same ventricle. The ventricle has fine crisscrossing apical trabeculations. It is a morphologically left ventricle. But you all know that in hearts with a dominant morphologically left ventricle receiving double inlet, there is also a small ventricular chamber. And if that ventricular chamber is right-sided, that permits the inference to be made that this heart also has a D-ventricular loop. And what we had not appreciated when we were introducing sequential segmental analysis was that both of these hearts, from the stance of Richard van Praagh, had atrioventricular concordance. And this was the beginning of the difference between us. Because Van Praaghian notation, if you have SD or if you have IL, then irrespective of how the atrial chambers join to the ventricles, this is atrioventricular concordance. And if you have SL or ID, again, irrespective of how the chambers and the ventricles are joined together, as long as you can identify the segmental notation, this is atrioventricular discordance. So when we introduced sequential segmental analysis, we wanted to differentiate between those situations in which, as you see at the moment, each atrium is joined to its own ventricle. We can have that when the atrial chambers go to appropriate ventricles and they go to inappropriate ventricles, or in the setting of isomeric atriums, when half of the heart is appropriately connected, the other half is inappropriately connected. We wanted to differentiate that from the situation in which there was either double inlet ventricle or when only one atrium joined to the ventricles, absence of the other atrioventricular connections. And there was nothing wrong with that, because you are all well aware that those situations do exist. And we now distinguish them on the basis of biventricular and univentricular connections. Had we appreciated, however, the meaning of concordance and discordance as used by Richard van Praagh, we should not have described those connections, which are biventricular, as being concordance or discordance. Instead, we should have specifically said that the hearts had either concordant or discordant atrioventricular connections, which is what we do now. The fact that we did not appreciate that led to perhaps the beginning of the divergence between the systems. Because Dr. van Praagh then argued that the atrial chambers did not connect to the ventricles because there were a connecting segment, and equally the ventricles did not connect to the arterial trunks. And he introduced this notion of the connecting segments, the atrioventricular canal, the conus. So do they exist? And indeed, you know they do exist, because we've also discussed this before. I've shown you this picture several times. It's a 4-chamber section across a developing human heart, Carnegie stage 14. The embryo itself at this stage is about 5 weeks old. So there you see the right atrium, left atrium, and without question at this early stage, we can recognize the atrioventricular canal. And it is of interest at this early stage, the atrioventricular canal is supported exclusively by the developing left ventricle. But there is also a developing right ventricle. And we can cut this 3-dimensional data set, and I can show you how the right atrium has no connection at this early stage with the developing right ventricle. But the developing right ventricle is supporting the entirety of the proximal outflow tract, which is conus. So no question but that connecting segments exist in the developing heart. But what we've also shown you is that with ongoing development, the atrioventricular canal becomes the vestibules. And in fact, that myocardium ends up in the atrial chambers, whereas the conus becomes the ventricular. Now protracts. So in the definitive heart, we no longer see those segments as anatomic entities. But to counter our approach of connections, Richard introduced the notion of alignments. And this, to me, is still the big difference between our systems, because alignments are not the same thing as connections. And we're going to illustrate that to you in the setting of classical tricuspid atresia. Because without question, in this heart, the right atrium, the incomplete right ventricle are aligned, but they are not connected one to the other. So connections and alignments, unfortunately, are not the same thing. Diane will illustrate that to you, again, using a gross specimen. Then Justin is going to show you how, using computed tomography, virtual dissection, you can all establish what is connected and what isn't connected, and how that is different from alignments.
This specimen has usual atrial arrangement and the classical type of tricuspid valve atresia, so that there is a morphologically right atrium to the right and a morphologically left atrium on the left. There are also concordant ventricular arterial connections with the pulmonary trunk arising from the hypoplastic right ventricle. You can see the characteristic muscular ventricular septal defect. And I'd also like to point out that this right ventricle has right-hand ventricular topology, so that I can put my thumb towards the inlet and my fingers towards the outlet with my palm on the septal surface of the right ventricle. The specimen has, by Van Praaghian terms, atrioventricular concordance, where there is alignment between the right atrium and the right ventricle. But you can see I can lift the right atrial floor off of the ventricular mass so that there is no connection between the right atrium and the right ventricle. So with absence of an atrioventricular connection, we have atrioventricular alignment, but it is not the same thing as having a concordant atrioventricular connection.
This is a CT scan from an infant with tricuspid atresia and transposition of the great arteries who underwent a Norwood operation with BT shunt. And so here we're looking directly anterior at the heart sitting within the chest. We can see the sternal wires from the initial surgery. And then we'll take out the heart from the chest into this endocast image, filling the blood pool. And we can see the broad-based right atrial appendage in the right atrium up to the right atrioventricular junction. We can also appreciate in this patient with transposition, the right coronary artery coming off of the native aortic root and coursing in that anterior right AV groove between the right atrium and the right ventricle. And then if we remove the myocardium from the right ventricle and just look at the blood-filled incomplete right ventricular cavity going up to the native aortic root, we can appreciate that there's only an apical trabecular and outlet component. There is no inlet component to this incomplete right ventricle. And so if we put the myocardium back on, then we can appreciate that while the right atrium and right ventricle are aligned, they are not connected in this patient with tricuspid atresia. And we'll rotate back to this right anterior oblique view, and again, appreciating the alignment between the right atrium and the right ventricle, but without connection. And then we'll go into a virtual dissection. And so as we cut into the right atrium and we see the base of the right atrial appendage, here's the superior cable vein draining down in the right atrium. There's a large interatrial communication. And then we'll rotate to look down at the vestibule of the right atrium. We can appreciate that broad-based right atrial appendage with the pectinate muscle extending all the way down to the vestibule of the right atrium with tricuspid atresia. There's, again, no connection between the right atrial cavity and the right ventricle. And that's much different. If we look at the left atrium, we can see that finger-like appendage of the left atrial appendage with the pectinate muscle extending but confined within the atrial appendage and not extending down to the smooth vestibule of the left atrium. We can appreciate the mitral valve and the connection between the left atrium and down into the left ventricle. Then if we look at the great arteries, this was the pulmonary route. Now after the Norwood operation is now the neo-aortic route, and this is the native ascending aorta, and we'll get down into the native aortic route. And you can see the coronary arteries coming off of the native aortic route, and here's the left ventricular outflow tract. We've now cut down into the left ventricle, the left ventricular outflow tract into that neo-aortic route, what was the pulmonary route. And just below that is the interventricular communication that communicates from this normal tripartite left ventricle over into that incomplete right ventricle. So there we've cut down into the interventricular communication, communicating between the left ventricle over into that incomplete right ventricle and the native aortic route. And we'll rotate into a 3-chamber view, looking at the left atrium, that large interatrial communication over into the right atrium. Here's the tripartite left ventricle. There's the mural leaflet of the mitral valve. So this is the inlet, the apical trabecular, and then the outlet component of the left ventricle. Here's that interventricular communication going over into that incomplete right ventricle. And we'll cut into that so we can see the extent of that incomplete right ventricle. So the apical trabecular component and the outlet component, again, with no inlet component in the setting of tricuspid atresia, up to that native aortic root in the setting of transposition. And then we'll rotate, so we're looking directly from the posterior aspect at the anterior wall of the left ventricle at that small interventricular communication sitting just inferior to the pulmonary root, what has now been created into the neo-aortic root. And then we'll cut anteriorly again into that incomplete right ventricular chamber up to the native aortic root.
So there we are. I've introduced to you the differences between the initial segmental approach and what we now call sequential segmental analysis. Because I don't think any of you would doubt that in the majority of cases, the cavities of the segments do indeed connect across the junctions between them. And now you've seen that in some instances, we've chosen to illustrate this in the setting of tricuspid atresia, a connection can be absent. So alignments are not the same thing as connections, and we need to take that into account when we compare our two approaches to the analysis of the congenitally malformed heart. Because if we recognize the differences, we can now heal the schism, because you will all appreciate that the differences, in fact, are very minor. We both depend upon the morphological method to determine what is morphologically right, what is morphologically left. We place our emphasis, however, in the atrial chambers on the anatomy of the appendages, and we describe the veno-atrial connections. So this is doing no more than incorporate the notion of the morphological method, which, as I've emphasized, was introduced by Richard Prague. And then, for the analysis of the remainder of the heart, we concentrate upon the connections, because the connections are a real thing. And that's what we're going to do on our next 2 sessions. So the next session in 2 weeks' time, we're going to illustrate to you how, by looking at the way the chambers join or do not join across the atrioventricular junctions, we can account for all the variations. And then with our final approach, sequential segmental analysis, we're going to look at the ventricular arterial junctions, and we'll revisit then some of the topics that we were discussing last session when we addressed the whole issue of the ventricular outflow tracts. But hopefully today we've introduced to you the potential differences between the segmental approach, sequential segmental analysis, and hopefully you will appreciate there is very little difference in reality between them, and it should now be an easy matter to heal any differences that might still exist.
Thank you very much, Dr. Anderson and team. It was a very nice presentation today. I think we can start as usual with Dr. Silverman making his comments, and then we extend to the other panelists, and then we go to the questions. Guys, please text your questions on the Q&A chat box.
Thank you very much, Grace, and thanks to the presenters today for absolute clarity of the information. I'm pleased to see Dr. Adrian Cruchon here, because the question that I have is basically something that he's posed, that the right atrium where the pectinate muscles are existing are entirely appendage. What I want to know is, if that's the case, what is the true part of the right atrium that isn't part of the appendage, that's part of the primary heart field?
So I'll probably start, and then Professor Anderson can add further. We were just chatting about this, and in all cases, the pectinate muscle goes along with the appendage. It's intrinsically an appendage structure. What happens, the difference is that, of course, on the left side, the appendage, the left atrial appendage, is far away from the septum, because the pulmonary venous component and the body of the left atrium, they are quite large. So you can see it well distinguished with a narrow connection with the rest of the atrium, and you can say it's confined. What happens on the right side is the same thing. What this may appear confusing is that because the body of the right atrium is so small, and the venous component is longitudinal, whereas on the left side is more, or horizontal, let's say, and the connection of the right appendage is broad-based, it can insinuate itself all the way. But mind you, the vestibules are smooth on both sides. They are not populated by pectinate muscle. Pectinate muscle is only belonging to the appendage. Is the way that inserts itself towards the crux, that and the smallness of the body, and the ventricular, the venous component, that gives the appearance that the pectinate muscle with the evade will not be confined. It is confined on the right side as well. And this probably, Professor Anderson can add how it links with the development in the embryo, when the shift of the sinus venous horn happens to the right and when the ballooning happens.
Yes, what you say is entirely true, Adrian. And in the past, we have said that the pectinate muscles extend around the junctions, but as you say, they still belong to the appendage. And so that is what we should now be stressing. It's the relationship between the pectinate muscles and the vestibules that is the key. And as you say, the body of the primary heart tube, which provides the body of the atrium, is unequally divided between the two atrial chambers, as you also say, and as we saw when we discussed development. Initially, the systemic venous sinus is also bilateral. But as it moves rightwards, then only a very small part of the body ends up in the right side. And that is why the appendage comes all the way around the front of the atrium, and why the pectinate muscles come all the way around to the crux. But it is indeed the case that in both appendages, the pectinate muscles are confined within the appendage and indeed identify the appendage. It's just that on the right side, the appendage is very much larger and occupies the entirety of the anterolateral wall of the right atrium. On the left side, the appendage is tubular and is separated from the septum by the body and by the pulmonary venous component.
Can I introduce my opinion about the vestibule? in the last couple of months, I had an opportunity to look at the so-called 4D images from MRI from Los Angeles. So I reviewed 200 cases, including a couple of isomerism cases too. And then what I find very interesting about the vestibule is that it appears to small area in dilated heart. But when ventricle contracts and atrioventricular junction moves down, and vestibule is not a small structure because it's stretched down. And then vestibule is a significant part of atrium. In that regard, what Adrian was there talking about was that pectinate muscle extent. So we usually, it is usually described that pectinate muscles in right isomerism go all the way down to the atrioventricular junction. Actually, that is not.
No, we've never said that. That's not true.
I think the recent description was absolutely right.
June,
Pectinate
that's not,
muscles
that is
go
not
down
true.
to the dorsal wall of the vestibule, not the AV junction. I think that is an important one. And then also,
totally incorrect. You are misleading people. We have never said that the pectinate muscles go down beyond the vestibule. That is simply not true. Yeah. We've always emphasized that in the morphologically right atrium,
I'm not arguing.
Extend between the venous component and the vestibule. What you just said is not true. You must not peddle things that are not true.
Yeah, no. I'm just opening that the paper Lumba and you published, and it still describes with no spillage to the dorsal parts of the atrioventricular junction. So that is the why that I see that here it should be changed to vestibule instead of atrioventricular junction. And then actually it does not go to the crus cordis either, because crus cordis is lower structure, and then pectinate stops above crus cordis.
Of course it does. We've always, it's the crux cordis, in fact, has never been accurately defined, and what you say is true. But when we said about the atria, the spillage, we were talking about the circumference of the atrioventricular junction, not the top to bottom. We've always said that the vestibule interposes between the pectinate muscles and the hinge of the valvar leaflets.
I do not think that you and I have any disagreement about that. What I'm saying is that in dynamic imaging, vestibule is pretty long. That's, yes.
I understand what you're saying there, and I think that's a very important point you make. And as you say, when we see it four-dimensionally, you can then see, and I agree that the whole thing moves down with ventricular systole.
So I think that this discussion is very interesting, because we had to find something to talk about because the rest of it was so absolutely clear. Anyway, thank you for answering my point, Adrian and Bob and June. It certainly does make a lot of sense that when we discuss these things, we bring clarity to them. And I think that's the important issue.
We don't always bring clarity.
I think
well, sometimes we just bring claret, Bob.
I think it shows how important the imaging is. As it was shown initially, we relied on angiography, then echocardiography comes along, and then now CT, advanced CT. So nomenclature will change, of course, with the evolution of the imaging. And it will bring more clarity, I think, and that's why it's important each and every term, how it's used.
The point you make there, Adrian, not only does the nomenclature change with the imaging, it also changes with our understanding. And my own understanding and the points that June has made. I mean, we do not always describe things when we write about them the first time with the clarity we would like to achieve. So that is why it is so important. We should not look back at what we might have written 25 years ago. What we should be judged upon now is how we write things now, because I accept that the clarity we provided was not always absolute, but we try to improve all the time. And the point June makes is a very good one, But again, our initial descriptions were less than perfect, which is why we try to improve all the time.
Can I just make some comments leading on from that? I mean, the understanding has been greatly enhanced by imaging. And previously people were using mostly 2D echo to understand the heart and how to for example, find their way around the heart. And the beauty, I think, of well, two things about the CT. One is that you're seeing the heart as it lies in the chest, and particularly you're teaching people how to move a catheter around the heart. If they don't appreciate how it lies in the chest, they get into trouble. It's a simple maneuver. Crossing that tricuspid valve can become very difficult. So understanding that's extremely important. Also, the CT gives these unusual views, which are difficult to obtain by traditional 2D echo, which really enhances understanding. It really makes a huge difference. The last point I want to make is basically the whole thing is, to my mind, about sequential analysis is you're looking at segments according to their internal organization, right? And I find that other systems, to my simple Irish mind, I can't understand them at all. Much more elegant.
Alan, it's a long time since you had a simple Irish mind. You've been in the UK, in England, long enough to become a little bit biased.
More sophisticated.
There are interesting questions if we want to address. The first one, why we think that the terms infracrystal and supracrystal are not the best. I can give my own understanding, but
well, that's simply because the crystal is a terrible term in itself, and when we talk about infracrystal and supracrystal, it isn't the crystal that varies, it's the thing that is called the crystal, and we pointed that out in 1977. So some of these things take a long time to, this is why I say we have to move with the times and understand what's going. Now we can see the different components that have been called the crista. And the problem was people were calling different things the crista.
For me, it's also important because it comes from the supraventricular crest. So if you talk about the structure being supracrystal, it means like it's supraventricular, which feeds into considering the connecting segments that are outside the ventricle.
You've frozen.
That's why I do not have ventricular, because when you say supracrystal, you refer to the ventricular crest. Well, so that's why I don't like it.
In fact, that's not strictly true either, because the ventricular septal defect that is considered to be supracrystal lacks totally the subpulmonary infundibulum.
Yeah.
And it's still above the crest of the ventricular septum. So as I say, it's the component of the crista that is no longer present. And I think it's a terrible term, but maybe we'll get into that when we move on and we talk about ventricular septal defect. But now I don't think there's any need to use these terms at all, because we can see exactly what's going on.
There is a question about the carotid arteries being used as branching, reliable branches for identifying the trunks, the aortic versus other trunks. What do you think about that?
I think that, I mean, the point is made that the subclavian itself can be anomalous, but I think you take all of the systemic arteries into, I mean, June might be in a better position to answer that. I see no problem in using any of the brachiocephalic arteries. I think that the pulmonary arteries typically arise from the pulmonary trunk. The brachiocephalic arteries arise from the aorta. You can have, I've never seen the situation where there is total balance between anomalous systemic and anomalous pulmonary arteries, but I'm sure it will arise sometime. June, what is your thought about that?
I think there is a very tricky part, because that we really try to define anything by words. But however, by the defining words what the pulmonary artery should be and the aorta should be, there is some issues. What if there is the anomalous origin of left coronary artery from the pulmonary artery, and right pulmonary artery arises from the ascending aorta? And then something like, it's impossible to define the aorta and pulmonary trunk
Have you ever
defining by words? So
Mike,
I think it is more on the common sense rather than really by defining words.
But have you ever seen that combination?
I would say that here, let's say, did I see that combination? I'm just thinking about, but however, that can happen. Anything can happen. Yeah.
But we think anything can happen. I've thought about this for a long time because I've never seen the situation in which you have two arterial trunks with each of the arterial trunks giving rise to a coronary artery, a pulmonary artery, and two systemic arteries. So I have never seen, and I am unaware of that situation ever being described. So in my opinion, as far as I know, we are still in the situation that it is possible to distinguish between a pulmonary trunk and an aorta, even when you have anomalous origin of small parts of the typical circulation. I've never seen the complete balance with two arterial trunks, one trunk each giving rise to a coronary artery, a pulmonary artery, and systemic arteries.
I haven't seen either, but however, it is reported this. Pulmonary arterial trunk does not give rise to any pulmonary artery, but connects to the descending aorta through ductus arteriosus. Yep. But ascending aorta gives rise to both pulmonary arteries. That is reported in the literature. Yes. Then, how you define that the non-aorta there? So no branch to the lungs, right? But
as you say, in that circumstance, the aorta is giving rise to both coronary arteries, to all the systemic arteries, and then you have anomalous origin of both pulmonary arteries. I think there, if you were confronted like that, with that, you would have no problem in distinguishing the pulmonary trunk from the aorta.
So that's why I'm saying that it should be more in the common sense rather than defining by words. Yeah.
But then you have to put the words to the common sense. Common sense, it means the words.
And Dr. Womack is asking further, how often you've seen the carotid arteries arising from the pulmonary trunk or branches?
I've never seen that. I've seen interruption. So I've seen, isolation with them arising via an arterial duct. But again, you can distinguish that.
Bob, I have a case here at All Children's that has the left coronary artery arising from the pulmonary trunk. There's an interrupted aortic arch between the brachiocephalic trunk and the left carotid artery, with the left carotid artery arising from the right pulmonary artery, and the left subclavian from the distal portion of the arch.
But despite that, you can still work out which is the aorta, which is the pulmonary trunk.
Yes. But as you said, it's common sense description. And as you've taught me over all the years, if you describe what you see, you can work it out easily.
And that is why you do need the words. I agree with June that we need common sense, but common sense will only work if you use the proper words.
And again, the ever-present question of ventricular inversion.
It's a no-no question, because inversion should be banned. We should either talk about mirror imagery or upside downness.
I think that people don't understand that mirror imagery refers to left-right, and inversus or inversion refers to up-down. I think you need to make that absolutely clear.
Indeed, you have done that perfectly. That is why words are important.
Exactly.
And I keep on saying, if we have the coffee cup, and if we invert the coffee cup, the coffee goes on the floor. Whereas if we mirror image it, we can still drink it.
Good point.
So mirror can be on your desktop.
Correct. We can argue about mirror imagery, June.
It's actually, unfortunately, it's interesting that we're having this discussion, but the clarity for today's session, not only your ideas, Bob, but also Diane's spectacular images and Justin's new advances in showing us this, it just solidifies things so clearly and well that there really is almost no room for comment. The only
No, I
comment
just
that
wanted
I
to-
have is
Norm,
being
can
exposed
I-
to the Van Praguian philosophy here a lot in the United States. The people seem to be quite reluctant to change their habits. And that is more, I think, a question of behavior and psychology than it is on science.
Bob, I just wanted to ask a question also, just back to the inversion, which we won't mention that word anymore. Number one, when we talk about topology, one of the subtleties, I think it's always implied, but it's really referring just to the right ventricle. When you say right-hand topology, left-hand topology, we're talking about the right ventricle, correct?
Correct.
And when you have a right-handed right ventricle, you obligatorily have a left-handed left ventricle and vice versa, always?
Correct.
And there's no isomerism within the ventricle. So you can't have two right-handed, like a right and right-handed left and right-handed right at the same time.
I have only ever seen two hearts in which there has been the suggestion of ventricular isomerism. And I'm not even convinced that that is the case. I don't think you can, in fact, have ventricular isomerism.
Correct. And just as a point, again, a surgical relevant point, when you have right-handed topology and a left, basically a left-handed left ventricle, conduction system is in a normal posterior inferior, say, rim of a VSD. And is the reverse true when you have right-handed, to be left-handed right topology and a, am I getting this backwards? When you have what people would call inversion is the conduction system always in an anterior position.
Not if you have mirror imaged heart with concordant connections. So if the atrial chambers are also mirror imaged, so you have the total mirror image normal heart, the conduction system itself would be mirror imaged. So the relationship between topology and the conduction system is complex because you also have to take note of septal alignment.
I think we'll have
probably more about that later.
we'll have a session on conduction, I think, isn't it?
Correct. I mean, Grace has asked that perhaps we can have a session specifically on conduction. And I think, so as I pointed out in my comments, in the next session in 2 weeks' time, we're going to talk about the atrioventricular junctions. In 4 weeks' time, we'll talk about the ventricular arterial junctions. And then for our final session of March, we will have a session on the conduction system.
Good. One question on the juxtaposed appendages. How do you think that affects the arrangement of the atrium at the atrial level?
It doesn't. I've just seen the most exquisite analysis of juxtaposition of the atrial appendages from the All India Institute in New Delhi. And they have identified juxtaposed left atrial appendages. And for the first time, they have shown a case with juxtaposed right atrial appendages. So you can have juxtaposition with any of the 4 types of atrial arrangement. All juxtaposition means is that the appendages are to the same side of the arterial pedicle rather than to opposite sides of the arterial pedicle. Is Grace still with us?
I'm here, Dr. Anderson.
So how are we doing?
We are doing fine. I just want to acknowledge that for this session, we had almost a double of the attendees that we are having lately. And we have people from Cambodia to Peru. It's been an amazing session highlighting how is important this topic. And I'm very happy that you're going to have 3 and not 2 sessions about it.
Indeed. I mean, there are so many things we need to discuss. And Adrian keeps on asking me questions that need to be answered so we can go on. And I have to say, it's also very good to have Alan and June with us because the questions, and also Q with Diane, it's this sort of questions that we need to move us forward because we all continue to learn. And that's what we're learning from that's what we are gaining from these sessions. And it's only when we pose the questions that we begin to get towards the answers.
This is true. I think we've answered most of the questions in the Q&A chat box. Do you see any other question that we should talk about, Adrian?
Yes, so juxtaposition is not related to isomerism. Someone is asking whether there is always isomerism in juxtaposed appendages.
Oh, absolutely not. I mean, in most, typically we see juxtaposition with usual atrial arrangement. And then we can have right juxtaposition. More usually it's left juxtaposition. And that means that the right atrial appendage moves behind the arterial pedicle and lies alongside the left atrial appendage. And then right juxtaposition is when the left atrial appendage moves through the transverse sinus and lies against the right atrial appendage. So all it means is the appendages are next to each other rather than being separated by the arterial pedicle.
Yes, Bob, and you'll remember that I did present a heart here where there was left isomerism with bilateral right juxtaposition of two left atrial appendages.
Yeah.
So I'm very interested in the All India experience. Of course, they've got so many phenomenal cases. It will produce a lot of insight into this whole issue.
I mean, they are producing the most amazing series. They're publishing them mostly in the Journal of Cardiac Surgery. I review regularly for the Journal of Cardiac Surgery, and that I think is where their analysis is going to be published. But as you say, they have so many patients, and the computed tomography that now is coming out of AIMS is just mind-blowing. They keep on sending me, or at least the journal keeps on sending me these cases that they turn up at the drop of the hat, and their experience is just amazing, awesome, as Jeff Jacobs would say.
Yes.
I think we'll address the other questions on the next sessions, especially Dr. Algonaid Omer. It's a good question for the next sessions.
Can I ask you one question to Dr. Anderson? So when there is only one identifiable ventricle, would you call indeterminate ventricle always or differently?
Now that's a very good question, June. And I mean, you will know that there are cases with double inlet right ventricle where the left ventricle is so tiny that it's not found until you do histological examination. And I've seen two of those. So two cases where initially I thought it was a solitary and indeterminate ventricle. I cut histological sections and we found a tiny left ventricle. So you might think it's a solitary ventricle. If it then comes to histology, it'll turn out to be a right ventricle. I think that is something that you can only resolve if you have access to maybe
Micro CT.
Micro CT might.
The reason why I'm asking is that just yesterday we had a case with absent left AV connection and mitral atresia, so-called, and then no identifiable left ventricle. But however, big ventricle is of no question is right ventricle. And then by kind of logic, it should be called indeterminate ventricle. I'm talking to my fellow, forget it. It's right ventricle whatsoever.
I think in those circumstances, June, if you get to micro CT, you would find a tiny left ventricle. Was the double outlet from the right ventricle, or was it aortic atresia?
No, it's the hypopressic left heart syndrome, sort of.
So with aortic atresia as well.
Yeah, aortic atresia, yes.
Yes, I think that is a situation where the left ventricle has been so tiny that it's just disappeared. I think that, I mean, you know, my own view is that hypoplastic left heart syndrome is a spectrum, depending on the time the insult develops during development. And I would anticipate that would be the earliest type where the left ventricle essentially disappears. But I think it's your own opinion that if you look carefully, we would find the left ventricle.
And Dr. Jason Tan is asking, when the appendages are isomeric, how do we describe the ventricles? He uses mirror image ventricles, but I think it's the position of the ventricles.
Why would that be a problem?
I think he refers to the topology, using the topology in this case.
But that wouldn't, the topology has nothing to do with the appendages.
No, it's not. He's just asking when the appendages are isomeric, how do we describe the mirror image ventricles? This is the actual question.
Well, the ventricular topology then speaks for itself. I mean, you analyze, as Diane showed you. I mean, you look at the ventricular mass. If there are biventricular atrioventricular connections with isomeric atrial chambers, then there are mixed atrioventricular connections, and we will discuss, and Diane will be illustrating that in the next session in 2 weeks' time. So he will have to be patient.
Of course, appendage morphology doesn't talk about the rest of the atriums or the atrioventricular connections.
Of course.
And I think that's maybe what Dr. Tan is having an issue with, because the appendages are not how you describe the AV connections.
Indeed.
Is that what Jason is talking about?
I mean, the appendages tell us what the atrial arrangement is, but as you say, then we move on. Having identified atrial arrangement, we look at the AV junctions. That's what we're going to do in 2 weeks' time.
Exactly. So
Okay.
in 2 weeks, we'll have that answer.
Indeed, indeed. Yes.
Well, we've had an extensive session on perfection, which is quite amazing.
It was really amazing. Very good session, guys. Thank you for all the panelists today, and thank you for you, Dr. Anderson, and all the team that put all of these beautiful images together.
Well, Grace, let's hope the panelists will continue to join us, because it's good to have June and Alan with us, and they illuminate the discussion.
Yeah, it's very nice. Thank you, guys. Thank you very much for your time and knowledge.
We need a little bit of Irish humor to get us moving.
Okay.
Thank you very much, everybody. See you in the
Thank you.
next session.
Thank you.
Thank you.
Bye-bye.
Bye. Bye.
All right.